morning. In this session, we will be discussing about a treatment modality which can be and should be used for every low birth weight baby in any and all scenarios, kangaroo mother care. Our aim is that by the end of the session, we learn about what is KMC, benefits of KMC, babies and providers who are eligible to take and give KMC, different scenarios where it can be given and its various components. KMC is placing the infant in skin-to-skin contact with the mother or any caregiver. It was first devised by Dr. Edgar Ray in 1978 in Colombia as an alternative to an incubator care for low birth weight babies. Low birth weight babies are those babies who are born with a birth weight of less than 2.5 kgs. KMC terminology has come from kangaroo pouch, where the kangaroo mother keeps the baby for a prolonged time for its growth and feeding, etc. Eligibility criteria: all the babies who are less than 2.5 kgs, who are hemodynamically stable and on minimal respiratory support should be kept in KMC. Though in some centers, even babies who are on ventilatory support are being kept on KMC. Also, babies with hypoxic ischemic encephalopathy or encephalopathy due to any reason are candidates for KMC, as it provides early intervention in all the sensory domains. Who can give KMC? Well, the mother is the best candidate, but any family member who is willing to give KMC can give KMC, but he or she should maintain hygiene and should be free from any serious illness. What are the benefits of KMC? It has benefits to all the parties concerned: the baby, mother and the family. For the baby, KMC helps in temperature regulation, which decreases the chances of hypothermia. It reduces the chances of infection. It also improves the breastfeeding rates and promotes better growth of the infant. It has been shown to reduce mortality and improve the IQ and neurodevelopment in the infant later on. For the mother, it improves bonding with the infant. It instills more confidence in the mother. It increases milk production and ultimately reduces stress and postpartum depression. For the family, as it reduces the length of hospital stay of the baby, so ultimately reduces the hospital expenses. Where can KMC be given? Well, in all the settings where low birth weight babies are cared for, KMC can and should be given. Whether it is a primary healthcare setup where advanced neonatal services are not available, there KMC can decrease newborn mortality. To a tertiary care health setup where advanced services are available, it can be used as an adjunct to the technology, where it will decrease the morbidities in the small babies. It is also to be used at home after discharge of these small babies and also while transporting the babies from one setup to another. Components of KMC. There are three components of KMC: kangaroo position, nutrition and early discharge with follow-up. In KMC position, baby has to be put between the mother's breast in the upright position with the abdomen of baby to the mother's epigastrium. Head should be on one side with slight extension. Baby's bottom is to be supported by hands or any clothes. Baby should be flexed and abducted at the hip joint. Arms should also be flexed and eye-to-eye contact with the mother should be encouraged. Once taken in such a position, KMC should be encouraged as long as possible, but for at least 1 to 1.5 hours, because otherwise excessive handling will cause more harm than the benefits. For the mother, she should be comfortable in a semi-reclined position, which also prevents the gastric reflex in a neonate. To ensure skin-to-skin contact during KMC, the mother should wear a front open dress, which may include special cloths like KMC bag or may be as simple as a sari blouse with a blinder, which may retain the baby. Baby should wear cap, socks, nappy and any front open sleeveless shirt. The aim is that baby's maximum skin should be in contact with the mother's bare skin. Second component of KMC is nutrition. The goal is exclusively or near as exclusive breastfeed as possible during KMC. If that is not possible in view of low gestation of the baby, then Katuri spoon or naso or orogastric tube feeding can be given during KMC. Third component, discharge and follow-up. That is, small babies are to be discharged home early when adequate follow-up and support services are available, and KMC is to be continued at home. What are the requirements of KMC? Healthcare facility which encourages family-centered care, where mothers and attendants are allowed 24-hour access to their babies. It should have comfortable reclining chairs or beds where KMC can be given. Staff and healthcare professionals who are trained and sensitized for the need of KMC, who can assess the mother or the provider in KMC. Appropriate clothes both for the baby and mother should be there. After discharge, adequate and appropriate follow-up should be ensured. KMC at home is possible only if other family members support the mother and cooperate in her conventional responsibilities of household chores. Well, when to start KMC? Simple answer is as soon as possible after birth. Though, if the baby is sick and requires treatment, then it should be started after stabilization. Now, there is a concept of KMC, that is immediate KMC, where baby is delivered on the abdomen of the baby, on the abdomen of the mother, and if requires admission, then the mother-baby diet are shifted together to the place of care. Till when to continue? Till the baby is around 2.5 kgs or equivalent to term gestation. At this time, baby will automatically start wriggling out and become fussy during the KMC. Though KMC can still be given intermittently at this point of time, when the baby is cold or after bath. There are some things to be taken care while the baby is still in KMC. First, the mother-baby diet needs privacy. You cannot expect that many people are crossing the area and staring at the diet. Mother should be comfortable while giving KMC. Second, the baby needs to be monitored while in KMC. It should be ensured that the baby's neck is neither flexed or not too extended, otherwise may compromise the airway. Baby should be monitored that breathing is regular, color is pink, and maintaining temperature during the KMC. Third, as already mentioned, when KMC is initiated, at least 60 to 90 minutes of sitting should be ensured. Similar sittings can be repeated as many times as possible during the day. Practice that is followed in NICU. Any low birth weight baby when gets admitted in NICU is first stabilized. Parents are counseled about the KMC, the benefits and how to do it. KMC is initiated in NICU, assisted and monitored by our nursing staff. Mother or any family member is allowed to do KMC. We generally start with 2 to 3 settings each, lasting 2 to 3 hours. Gradually, KMC is increased to 4 to 5 settings per day, each lasting 3 to 4 hours, covering a total of around 12 to 15 hours in a day. After recovery, the baby is discharged with advice for regular follow-up and KMC is ensured at home. The family is counseled about the support and cooperation required by the mother for the same. In the OPD, again, its importance is emphasized and is ensured that family is giving KMC at home also. So, the take home message is KMC should be given to all small babies in any and all scenarios possible. It should be started as soon as possible and given for as long as feasible. KMC can be given by any family member and not only mother. These are my references. Thank you.